So there's three parts to it. The first part is the patient history. Okay, if you're videoing that, we don't want to see that. You have to have it done. So if you're videoing it, you're going to send that part in completed, and then you're going to send the head to toe part, which we're getting ready to look at. If you're coming to do it live, fill this out before you get here. Okay, so that part is all filled out. So we don't want to see you fill this out whether you're on video or you're doing it live. Okay. If there's anything abnormal in the history, you need to address that in your head to toe. Okay. So if they say they've got peripheral vascular disease and they have very poor pulses, and you document that in the history, you know, when you get to their pulses, you probably need to feel poor peripheral vascular disease pulses. All right. So on this, you see here the points available, 20 points for the history. That's easy. We're just going to fill that out. And then see, this is where it tells you how many points. So if you leave out 3 or 4 of these, I mean, you can basically grade this before you get started. Okay? Also, follow this through exactly the way it goes. We've built this out in a real logical way. Okay? So do it in order. Okay? We have a lot of people that want to go from the head down to the feet and then just scatter all over the place. It's very hard. It's very hard to grade, and it's also, they leave stuff out. Okay? Those are the people that aren't successful. So try to go in the order here. Okay? So that's what we're going to do right now. So I'm going to do the physical assessment. Of course, you'll come in and introduce yourself, let them know that this is confidential, etc. And we start with our thing there. So the first thing is, we're going to inspect the skin of the face and the head. Okay, and we always inspect first. So we're just looking, the hair as well is even. There's no dry areas. There's no lesions on the face. The skin is clear, symmetrical. Ears and everything are symmetrical. And expression, again, normal expression. We will go to palpating at that point. Again, we just don't feel any nodules, any soreness or anything. And if there is, you'll let me know about that. We will look at the temporal arteries, and we'll do these on both sides. Okay, and we're just, again, feeling that they are present. Okay, and they feel equal. Okay, then we will go to the TMJ, and basically what we're going to do is just palpate here, and if you would, open your mouth. Okay, and I don't feel any clicks. Was there any pain or anything with that? Okay, very good. So we then will go to cranial nerve 5, and this is where I'm going to ask you to clench your teeth real tight. Okay? Now, just resist me from opening your mouth. Don't close it. There you go. Okay, very good. And we will check again with cranial nerve 5. Just close your eyes, and if you'll just let me know when you feel the cotton ball. Okay, so he feels it on both sides. So cranial nerve 5 is intact. So now we will look at cranial nerve 7. So I'd like you to smile a little bit. Okay, frown. Okay, close eyes tightly. Okay, lift your eyebrows and show your teeth and puff out your cheeks. Very good. Okay, so that's it for the head. So next we'll go to the eyes, and we'll start with the visual acuity. So we've got a Snellen chart down here, and you guys, you can order this. You can print this off online. There's several places. If you just type in Snellen chart, you'll get with that. So I'm going to ask you to come down, and 20 feet is sort of pre-measured that at 20 feet. You can do this one of two ways. Some books will say have the patient start at the top and go down. Others will say just go ahead and read the lowest that you can read. And that's what I'm going to do. And do you wear corrective lens?
Yes.
Okay. Are they in?
Yes.
Okay. So first of all, if you will, cover up your left eye and read the lowest that you can read.
DEFPOTEC.
Okay? And that's 2020 in that eye.
DEFPOTEC.
Very good. Same. All right. Okay. Next, we're going to do cranial nerves 3, 4, and 6, and that's the extraocular movement. And basically, we're going to be looking at the six different fields. So we're going to start by having you stare at my finger and just follow my finger. Don't turn your head, so follow it just with the eyes. What we're looking for is, do both eyes follow conjugately? Do they all stay together, or both stay together? Okay. Up, and just don't move just your eyes. There you go. Very good. Okay, so next we're going to look at cranial nerves 3, 4, and 6 also. This is where we're going to, and in reality here, we would turn the light out maybe where we can see this a little bit better. And we're basically just going to look at the pupils. First of all, for size, his are both about a 4 millimeter, and they're round, they're equal. They do constrict to light, and they're consensual, so if I shine it in the left eye, the right eye constricts as well. Okay, and again, just looking at his eyes are green, the sclera is white, conjunctiva is pink and moist, there's no drainage or anything like that. Okay, the other thing we're going to look at is the other external parts of the eye, the eyebrows, eyelashes. There's good symmetrical growth, no nodules or anything down below. The other thing we're going to do is test for accommodation, and basically how we're going to do that is I'm going to hold the pen light about 12 inches from his eyes, and I'm going to ask him to focus on that, and then he's to pick an object back on the wall, and when I ask, he will focus on that. What we should see is when the pen light is up close and he focuses on those, the eyes will sort of come together and the pupils will constrict. Okay, and then when he looks at the distant object, when he focuses on that, they will go back to more midline and the pupils will dilate more. And how I remember that: close constrict, distance dilate. Okay. Okay, if you will just concentrate on that. Okay, they sort of come together, and now concentrate on the wall. Okay, and they do. They dilated out and constricted and sort of came together symmetrically when they were in the when they looked at the close-up object. Okay, next we'll go to the ear, and first we're just basically examining the outer part of the ear. Again, they hang symmetrically on the head. I don't see any drainage, redness, any pain at all in your ears. Okay, very good. So we then will look at cranial nerve 8, which is the whisper test. And that's just as simple as I'm going to occlude one side of your ear, and I will whisper a word, and you tell me what I say.
Football.
Okay?
Baseball.
Okay, very good. That was, I guess, a little louder than whisper. So we'll go there from nose. Again, like everything, we start out with inspection first, and again, it's symmetrical. I don't see nodules. There's no apparent drainage or anything. And the same as I look in. Okay, next we'll do patency of the nose. So if you will, just occlude one and breathe in. Okay, and then the other. Okay, very good. So they're both patent. And we will go to the maxillary and frontal sinuses. And I'm just going to sort of palpate these, and if you will, you let me know if there's any pain. Anything? Very good. Okay. And notice how I'm talking my way through this. So do the same thing as you guys are videoing yours, because if not, you're gonna be like what Lauren was there, just looking at my back, and you don't know what I'm doing. So talk to us and let us know what you're doing. You're not gonna necessarily do that in true life in a patient's room, but you need to for this. Okay, so we're gonna go from that to the mouth and throat. And again, first of all, we're just going to inspect. Okay, part of this would be tonsils. I know based on the history that we got before all of this that he does not have tonsils, so we won't be grading those. If tonsils were present, you would, and they're graded from a 1, which is they're not really visible, up to a complete 4, which they're touching each other and sort of occluding. And, you know, they would need to come out, of course, at that point. So if they were there, grade those. Okay, so first one just open. Okay, the tongue is moist, pink. The hard palate is, again, pink and shiny. Teeth, open. Teeth all appear intact and normal. Okay, again, open. Okay, say ah. Okay, I see his uvula, it hangs midline, and it does sort of go up when he says ah. We will open again. Gag reflex. Okay, good enough. Okay. We got that, we'll do the ah test, and I'd like you to stick out your tongue, okay, and move it from side to side. Okay, other side. Very good. Tongue protrudes midline and normal. Okay, for the neck, we will go to, again, the lymph nodes, okay? And, you know, there's 10 of these that we ask you to look at and just sort of learn these, and we've got them, there's a picture of this here. You can find this, these are in your book. You can type in lymph nodes of the neck into Google and it will pull up all kinds of pictures of that. But what we're going to do is we're going to palpate that, and what we're feeling for, in many cases you're not going to feel these, okay? You're not going to feel these. If you do feel them, they should be sort of spongy, somewhat soft, and movable. Where we get into issues if they're really hard, painful, and, you know, it'll move, not moving. So, again, just sort of take the time to learn these. Okay, so first of all, we're going to start with the preauricular, postauricular, and again, if there's any pain, please let me know. Okay, the occipital, which is sort of further back. Okay, coming around under the jaw, we've got the tonsillar, submental. I can feel the submentals, or excuse me, not the submental, the submandibular, the submental. Okay, the superficial cervical, deep cervical. Those sore. Okay, I can't feel those, but again, they're soft. They're not hard, and they are movable. Okay, the posterior cervical and the supraclavicular. Okay, very good. And do again, just call those out as you go, and you know we'll check those off as we go through that. Okay, so next we're going to test cranial nerve 11 by doing some range of motion, basically. So as first off, if you'll tuck your chin to your chest, okay, turn your head from side to side, okay, touch your ear to each shoulder, okay, extend your head backwards, okay, and turn against resistance. Okay, and that's symmetrically, it seems symmetrically strong on each side, and shrug your shoulders. Very good. Okay, so the trachea and thyroid on the neck. First of all, on the trachea, pretty much we're just sort of observing and making sure that it is midline, and his is doesn't protrude one way or the other. For doing the thyroid, the book will give you both things. It will give you an anterior approach where you can do it from the front. Most books will suggest the posterior approach is better for that. It would be very nice at this point if I had remembered to bring some water for him to drink, because we do need to ask him to swallow, and you're needing to fill the thyroid as it moves. Okay, so the first thing we will do is, and it's right at the cricoid notch, and you'll be able to feel it to the sides, okay? And what you will do is sort of press it over to the right and then back to the left where you're sort of squeezing it in between, okay? And then if you will swallow. Okay, and you should feel it move freely as he swallows. And again, it's firm. By firm I don't mean hard, but it's firm but sort of spongy. And that's the way that it should be. It should not be really hard. So that's how we do that. And again, water would be nice to help him with swallowing. Okay. Okay, the carotid pulse. And again, temporal, we could do both of these, but with the carotid, you're going to do one side at a time. Okay, and okay, it's regular. It's not bounding. And the same on the right side. At this point, we will listen for a carotid bruit. And if you're listening to bruit, what do we listen with, the bell or the diaphragm? Actually, the bell for this. So the small size, or the small side rather. And again, in listening for bruits, we're just listening for a turbulence of flow. So we're looking for partial occlusion in the carotid, which would be potential for stroke or whatever. So you should not hear a bruit. And what a bruit is, it's just going to be a swishing sound as blood goes through a more turbulent, smaller passageway. Okay, you'll breathe in and hold it. Okay. Okay, you can breathe. Okay, and breathe in and hold. Okay, and again, I didn't hear anything. We asked him to breathe in and hold, because if not, you're hearing the air going through. All right, so we are down to the chest. Okay, now we break this down into posterior and anterior chest. In real world, we're going to listen to breath sounds in the anterior and posterior. For the purpose of this, to streamline streamline things a bit, we're going to do the breath sounds on the posterior, and it tells you that on there. Okay, now I'm going to count off if you do both. Again, there's no need to. We're going to do breath sounds on the posterior, heart sounds on the anterior. Okay, so if you could just turn, if you can take your shirt off and then sit where I can see your back. We can. Okay, so first, just like everything else, we're going to just inspect, and everything is symmetrical. I don't see any obvious tumors, lesions, anything like that. On palpation, again, everything feels fine. Any pain anywhere? Okay, very good. So tactile primitus, first of all, and this is basically where we're going to feel bilaterally for vibrations. And what we're doing here is we're feeling for vibrations, and we're going to ask the patient to say 99. When he says that, you should feel a vibration on each side. What we're looking for is that equal. Okay, if one side is more vibrating than the other, it can be for things like congestion, that type of thing. I mean, how many times, especially if you've got little kids, if you're holding them or whatever, and they talk or you cry, I mean, you can feel the congestion there. So that's sort of what we're doing. And the purpose of that is a lot of the rural clinics in Mississippi, especially some of the poorer areas, you may not have access to an x-ray machine. Sadly enough, there's some counties, I recently learned in the state, that there's not even a physician at all in the entire county. So I mean, in a lot of times, just every assessment tool that you can use is good. And again, what we're gonna do, we're just gonna work our way down, and we're gonna be feeling bilateral. Okay, so when you feel me touch, if you'll just say 99.
99, 99, 99, 99, 99.
Okay, very good. And I could feel vibration as he said that all the way down, and it felt even on both sides. It wasn't, real coarse or anything like that. So that's what that should be. Okay. Again, percussion. When we do this, we should hear resonance is normal, and that's the higher pitch. And you're going to hear dullness over areas of, again, like atelectasis or congestion. Now, when you look at the videos, you're gonna see that it's talking about percussion like that. That will sort of work, but I found it best if you'll use like your reflex hammer. That would be the best. You get a lot better sound. And really, where we're on that reflex hammer is really the only thing that you're gonna need that you might not have. And these things are very inexpensive. You can get them on Amazon. You can get them at your wherever, doctor's offices have them, they'll let you borrow, or whatever. If you live here locally and you don't have one, call me or us and we'll let you borrow one. But again, what we're doing is we're comparing side to side, okay? Everything sounded, equal and not terribly dull, because you could sort of hear it resonating. All right, so we will do that, and then we will percuss the costovertebral angle. Okay, and what we're percussing here for is not sound but pain. So we're looking for kidney tenderness or anything like that. So with that, you're basically just going to strike and ask the patient, let me know if that's painful. Any pain?
No.
Okay, very good. So we're just looking for tenderness. Okay, at this point we'll auscultate breath sounds, again, bilaterally, and just working our way down. Deep breath. Again, he's clear and everything was equal. Again, notice everything that basically we've looked at so far has been normal on this patient, so we've really documented nothing through here. If you've got a normal patient, you're not going to really be documenting anything. There's areas for, if I noticed that he were congested or whatever, we would of course document that at that point. Okay, so if you can come back and turn this way. Okay, at this point we're going to go to the upper extremities. That seems like it falls out of sequence a little bit, but for everything else we're going to do after the upper extremities, the patient is laying down. So that's why we do this at that point. So again, just looking at the arms, again, everything is symmetrical. I don't see any lesions, rashes, anything like that. Okay. Pulses, we're going to feel 3. We'll do the brachial, and we can do those bilaterally. These tend to be like on the inner aspect. Sometimes they're fairly deep. Okay. And you may have to press down a little bit harder to feel those. Again, I do feel his, they are together. The radials. And ulnar. Again, ulnar at times can be a little harder to feel. And I don't feel those well, but the brachial's great, radial's great, so we're good. And I'm not the best pulse feeler, I'll admit. Okay, so capillary refill, we're gonna check bilaterally, and again, we're just pressing. They blanch as they should, and then the color it goes back to pink in less than 2 seconds. Okay, so from here we go range of motion. So if you'll just flex your arms above your head, okay, and then extend them back, okay, and now, okay, down, okay, very good. Now we'll do the elbows. If you can flex them up, extend them down, okay, and then pronate and supinate. Very good. And flex up against resistance, okay, and then extend down against. Very good. Okay, and now we'll do the wrist. So if you will up, okay, extend, and then hyperextend on down, okay, and then make a fist, okay, and then a finger to each thumb, our thumb to each finger. Okay, so we got all of that. That's all the range of motion. The next we'll test cerebellar function, and that is just where you'll have the patient, put their arms out to the side and come in to nose, finger to nose test, and gradually get a little faster. Okay, faster. Okay, very good. You will see some where the person will hold a finger out and they will ask the patient to go from their nose to that finger, nose to finger. But either way, but typically it's like we see here. Okay, the next thing we will do will be graphesthesia and sterognosis. Again, this is just testing mental neurostatus, and basically what that is, the first graphesthesia, this is where you draw a symbol or a number on the patient's hand, have them close their eyes, and just ask them to tell you what that was. So, close your eyes and tell me what number I did. 7. Okay, and then close your eyes.
3.
Very good. Okay, and then sterognosis. This is where you get a common object, and again, you ask them to close their eyes, place it in their hand, and they will identify what it is. Okay, so close your eyes. Cube. Okay, and other hand. Key. Okay, very good. And just make sure that you get an object that is common to that culture. A paper clip or something would be very common for us to use. But if you're working somewhere where there is a big migrant thing where they're working on farms or whatever, they may or may not have seen paper clips. So use something that would be common, a key, pencil, paper clip on most would be, but just sort of keep in mind that culturally that they will know what that common object is. Okay, so now for the reflexes. Okay, and now these give people a little bit of trouble, and that's okay. There's some the videos that are out that I have posted are very good, as well as if you just go to YouTube and type in triceps reflex, they will go through how to do all of these. So just sort of work with these. I'm going to do them just on one arm today, but you're going to do them on both. Okay, so we will do the triceps. This is basically where you just have them they drape their arm over yours, and the key to it is that their having it hanging, you know, completely limp, okay, that it's not flexed at all. The triceps tendon is right in here, and you're basically going to just strike that, and then you should see a flex of the tricep muscle. This is not going to be something that's going to be jumping out at you. I find every year when we're reading these, you can tell they've practiced a lot, because the patient, you know, will do this real abnormal jerking of your arm or whatever, but, you know, at least if we're doing it right, okay? This is just let it hang for a minute. And it's something you're probably not going to be able to see back there, but I mean, you can see that the tricep muscle does flex a bit. With the bicep, sort of the same thing. We're going to cradle their arm. The biceps tendon is right in here. Again, when you strike it, you should see a small flexion of the biceps muscle. And again, just make sure that you're supporting the weight. Okay, and we got that. And then with the brachial, that is right here above the thumb area. Let me use that one because you had surgery on that. And you should see the thumb twitch. Okay, very good. And when we'll do that, of course, on both sides. All right, so we are down to the anterior chest now. So this is where we're going to do heart sounds and work of breathing. So for heart sounds, we're going to do 4 different areas. So Leon, if you'll pull, or Ms. Puckett, if you'll pull that up, please. So we're going to do the aortic valve, pulmonic valve, tricuspid, and mitral. Now, you're going to notice these are not anatomically where these exact valves are, but they're where that you're going to be able to hear them the best. So for the aortic, it's actually on the right side, and it's down about the 2nd to 3rd intercostal space, right at the sternal border. So about right in there. And again, we're going to listen for both, or we're going to listen with both. So we're going to listen with the diaphragm for just the heart sounds, and then we will turn it over and listen with the bell, where we would be listening for murmurs or that type of thing. So I'll start out with just the diaphragm. And again, we're listening for S1 and S2. Is there anything extra? So, you know, S1 and S2 is going to be the typical lub-dub, and then if there's something in there extra, you would hear a 3rd heart sound or whatever. And then if it were a murmur or, you know, stenosis, something like that, you would hear a swishing sound, and we'll hear that dust with the bell. So we'll listen with both. So put that right in there. Okay, and very strongly I hear S1 and S2. Pulmonic valve is basically right across. So the 2nd to 3rd intercostal space, just right across over on the left sternal border. Okay, good sounds. And then we will listen to the tricuspid, which is about the 5th intercostal space down and at the left sternal border. Okay, so right in there. Okay, and that's heard well. And then the mitral valve, which again is about the 5th intercostal space and mid-clavicular. And then we'll turn that around and again listen with the bell in each spot as well. At this point, we're listening for murmurs. And we heard none. So, very good. Any questions on those?
When you are assessing those, do you need us to call out each?
Yeah, you could, yeah, I'd like, yeah, I do. And you don't have to go into detail of they're at, I'm at the 2nd to 3rd intercostal space. You just say I'm listening to the mitral, I'm listening to tricuspid. That'll be fine, and just roughly the right, I mean, we're not gonna, you don't have to zero in and show that you're putting in exactly, just so we're getting in the right, in the right areas.
So when you're in the aortic, you want us to do diaphragm, bell, then move to the next one, diaphragm, bell?
Usually what I do is I do one whole thing, so I start out with either diaphragm or the bell, go do all areas, and then switch over to whatever the other one. Now, and some of you will have stethoscopes, some of them like the master cardiology, and some of those, it's not one that you turn around, it's got, you know, they're a higher end stethoscope, and they're built into here both. So if that's the case, there's nothing to turn, and you would just say, you know, with this stethoscope, the diaphragm and bell is built in, and obviously you're just gonna listen with one, so whatever you want. And, when I started talking about all of these areas, I went a little bit that got me a little bit out of order. But, you know, first thing again we're gonna do is just inspection again, you know, work of breathing. It looks like everything is symmetrical. We can also attempt, and you're supposed to be laying down at this point, I'm sorry. But I felt like you could see those spots a lot better. Okay, so again, you know, I'm looking for any abnormal breathing. I see none. We would like to feel for any thrills or heaves, which would be any vibrations with breathing or with heart beating. Try to feel for the PMI, which is, you know, the point of maximum impulse of the heart. I don't ever feel that very well. Again, we try to look for, you know, the apical beat. Again, you may or may not be able to find that unless you've got just a real thin person, whatever. But anyway, look for that. Attempt to feel for that. You can, I mean, sometimes you can. I've had especially real frail patients that you're able to feel that well. Okay, also while we're there, never mind, we're gonna go into the abdomen. So again, the abdomen is one that we wanna pay particular attention to order. So what's the order that we go in for an abdomen?
For what?
For the abdomen.
For that.
So inspect first, then auscultate, then percuss, and then palpate. Because if we start out with deep palpation, that's gonna, you know, that may mess up the bowel, you know, the bowel sounds or whatever. So do go in order for that. You get 2 points for order. So, you know, work with that. So the first thing, just again, inspecting the skin of the abdomen, everything looks real good. The umbilicus is midline. It's not protruding like with a hernia or anything like that. I don't see any visible pulsations. You know, what we're worried about there is an abdominal aortic aneurysm or something that would cause pulsations. We don't see that. So the next is we will auscultate. And again, we're going to listen in all 4 quadrants. If they have very hypoactive bowel sounds, you know, you can listen for up to a minute a piece. But I mean, if you're hearing it, you heard it. So just, you know, you can sort of move on. Okay, and I do hear bowel sounds in all areas. So we go from that to percussion. And what you're going to hear is mixtures of dullness and tympany. Dullness over areas of like solid organs or solid areas, you know, impacted bowels or whatever. Tympany over air-filled areas, empty stomach, empty bowels, that type of thing. So then again, I go with, instead of doing this, you go with this. And you hear like over the area of the stomach, how you can hear how much more higher pitch that is. Okay, and you know, ask, is there any pain with all that? Oh, and one other thing I forgot in the auscultation, while we're also in the abdomen, we're going to listen for bruise in the renal artery as well as the aorta. So I would have gone a little bit out of order there. But the renal arteries, basically just to the left and right of the umbilicus, again, we're listening for, you should not hear this, okay? And so that's what we're hoping. I don't, and then the aorta would be midline, just above the umbilicus. And again, what we're listening for would be an abnormal whooshing type sound. Okay? Palpation, again, we start out with light palpation in all 4 quadrants and go down to deeper palpation. And again, we're going to ask the patient to let me know if you feel any pain during this, and also just observe their facial, if it looks like they're hurting. So again, we'll start out fairly light. And then go to deeper. Any pain? Good. Okay, and then palpating the liver, which is on the left or right side. Right? Okay. We'll have some people that will palpate it on the left. So we'll do that. Now, a liver in a typical patient, you're probably not going to feel. You feel livers when they're hardened, when they have cirrhosis or whatever. So you may very well not feel the edges of the liver. You may, but if it's a thinner person. But again, you may not. And basically, what we're going to do is put pressure down below and then sort of try to come up under the rib cage. So it's sort of a deeper type thing. And there's a couple different procedures. I mean, ways to do that out there. So you can look at those. But again, I can't say that I do. And again, in a healthy patient, you're very well not. In a young infant, you can, because there's the way they're built, that you can feel their liver real well. So if you want to, you can do. That's a good way to practice that. So then, did we do it in a proper procedure? I sort of didn't. So I might have gotten a half point knocked off for that. Okay, so once we get to that point, we're pretty much working our way towards done. We're down to the lower extremities with the patient still lying at this point. Again, just the same as always. We start out by inspecting. He's got uniform hair growth on these. There's no thinning of the hair. And feeling of it is it's warm. I don't see any edema at all. Okay. Let's go with our pulses that we're going to feel on here. We're going to feel 3. We'll feel the popliteal up underneath the leg, the dorsalis pedis, and the posterior tibial. They all are probably pretty good at feeling those. Again, the popliteal can be harder to feel at times. Okay. The posterior tibial. Those are very good. Dorsalis pedis, and again we'll do that. Okay, and I do feel all of those, and they feel normal. Okay, so now we'll go to range of motion. So if you can raise one leg, straight up, okay, then the other, okay, and then sort of bring them up to your chest, okay, and ready, go out, okay, back in. Same with the other leg. Okay, and then with the ankles, you can go pull them up, down, and we'll do that against resistance. Okay, very good. And while we're here, we'll do cerebellar function. If you could put this heel and run it down that shin, and then vice versa. Very good. Now for the reflexes, we're going to do the patellar, the Achilles, and the Babinski. So while I've got him laid down, we'll do the Babinski. And what's abnormal when we do the Babinski? What should we not see? Like a spreading, a fanning of the feet. Now you're gonna see them sort of go up, but they should not fan out. That would be normal on an infant. And this is usually pretty not uncomfortable. It's sort of strange feeling for them. So let them know what you're doing, and where it's gonna be raking. You can do that with a pen, you know, an ink pen type thing, or like the bottom of this is specifically what that's made for. Okay, you see they come up, but they don't fan out. So that's normal. And what I'm doing is sort of starting there and sort of curling over with that. Okay, so now the rest of it, you'll sit on the side of the table again. And we'll do the patellar, and that's just the typical, you know, knee thing here. And again, we're gonna strike right below, and you should see that come out. There we go. I'm just trying to get one. There we go. That's the one where you can tell the patient, the ones that really practice a lot for their video. And then the Achilles on the back, we're gonna hit that, and it should, the feet should sort of come up. Okay, so that's that. So now the very last part is standing. So if you'll just stand and if you'll walk across on your heels and back on your tiptoes. Okay, and then on each leg, just hop a couple times on each leg. Okay, and then the same with the other. Okay, and then the Romberg test is again for cerebellar function, and just if you'll just close your eyes and stand straight. And what we're looking for here is not an excessive amount of swaying. There may be a little bit. If you've got an older person or someone that you expect to be unstable, you'll make sure that you are ready to support them with that. Okay, and okay, so bend over straight. At that point, we'll look for, you know, spinal symmetry, and everything is symmetrical, and then sort of twist, and then bend to each side. And that's that. Pretty simple. Go by this book, by this piece of paper, and you're gonna have no issues at all with this. And I think it goes in a fairly organized way. So if you'll just follow that, and don't stress over this thing.